Hello, good morning, good afternoon, good evening. Whenever you are watching this video, I'm saying to you all, Assalamu alaikum wa rahmatullahi wa barakatuh. How are you, girls? Smart doctors. We would like today to discuss the topic, an important topic actually, and it's getting common in the field of obstetrics. And the prevalence of thyroid disease is increasing. So we'll be talking today about the thyroid disease in pregnancy. Our target today to discuss the normal physiological changes that occur to thyroid gland during pregnancy and to distinguish between the maternal and fetal outcome of thyroid disease and to recognize the options of treatment regarding hyperthyroidism or hypothyroidism in pregnancy and what is the best option of treatment available. And finally, to critically analyze the diverse of presentation to a disease called or a presentation called postpartum thyroiditis. You can see here the diagram of hypothalamus pituitary thyroid axis. You remember from basic science you have hypothalamus. The hypothalamus will be releasing the thyrotropin releasing hormone. Thyrotropin releasing hormone will go to the anterior pituitary. Anterior pituitary will, in response to its stimulation, will release thyroid stimulating hormone which go to the thyroid gland and stimulate the synthesis and release of thyroid hormone. And this is controlled by the amount of thyroid hormone available in the blood. The more thyroid hormone available in the blood, the less TRH, TSH release from hypothalamus pituitary. The more thyroid hormone in the blood, the less release of TRH and TSH by negative stimulation. In here, this diagram shows what happens in the thyroid cell, the synthesis of thyroid hormone. This happens by extracting more iodine from the blood during pregnancy and formation of thyroid hormone. This iodinization process, combining tyrosine, forming of thyroglobulin, thyroid hormone formation, all will take place with the help of thyroid peroxidase enzyme, TPO. So imagine if there is any antibody to this thyroid peroxidase enzyme, what will happen? Then the process of thyroid hormone formation will not occur. So if there is any antibody against this enzyme, there will be less synthesis of thyroid hormone. We can see here the histology of thyroid follicles. You can see the smooth cubical shape thyroid cells arranged in circles, smoothly, nicely, not interrupted by any inflammatory process. This is where the normal histology and physiology occur. So keep looking at this image because we will be comparing now the normal histology of thyroid follicles to the abnormal of the hypo and hyper. Just keep looking at it for a few seconds before you turn into the next slide. In this slide, we will be explaining the histopathology of Hashimoto's thyroiditis. It's an autoimmune process affecting the thyroid gland. It's triggered by autoimmune antibodies. These antibodies to the thyroid peroxidase enzyme. You remember in the previous slide we were talking about thyroid hormone synthesis and the role of thyroid peroxidase enzyme, which is important in the process of thyroid hormone synthesis. These antibodies will come and attack this enzyme in triggering inflammatory process. This inflammation will attract lymphocytic infiltration to the gland, causing lymphoid follicles. You can see here on the left side of the slide where there is lymphoid follicle formation and aggregation of the thyroid lymphocytic cells and atrophy to the thyroid follicles. On the right hand side of the slide, you can see the massive lymphocytic infiltration of the gland. Do you remember the normal histology of the gland in the previous slide? Go back to it and compare the normal histology of the thyroid follicles to this massive lymphocytic infiltration of the gland. You can imagine here, after massive infiltration of the gland by lymphocytic cells, there will be less hormone synthesis. So this will end up with frank hypothyroidism. So it starts with antibodies attacking the enzymes, enhancing inflammation, lymphocytic infiltration, and then massive lymphocytic infiltration, and Hashimoto's thyroiditis. Ends the gland with frank hypothyroidism. Here we talk about Graves' disease. In Graves' disease, there is diffuse enlargement of the thyroid gland. This gland is hyperactive and secreting excess thyroid hormone. And if you look closely through the histopathology, you will find that there is hyperplastic follicular epithelium. Can you see here on the right side of the slide where there is excess thyroid cells, hyperplasia of the thyroid cells and epithelium? So excess release of or formation of and release thyroid hormone. The state of hyperthyroidism in pregnancy can occur before pregnancy, during pregnancy, or after pregnancy. And that's why you have to be aware of that the most common cause of hyperthyroidism during the reproductive age group is Graves' disease. In this slide, you can see the pathology and the development of two autoimmune diseases affecting the thyroid gland. Hashimoto thyroiditis on the left-hand side and Graves' disease on the right-hand side. On the left-hand side, the Hashimoto thyroiditis is triggered by autoantibodies. As you remember, we said these antibodies are against thyroid peroxidase enzyme or against the thyroglobulin. These antibodies will trigger the inflammation in the gland, causing necrosis, apoptosis, and cell death of thyroid cell. So it will end up with hypothyroidism. On the right hand side, it explains the pathology and the development of Graves' disease. The antibody is thyroid releasing antibodies. So it stimulates the receptors of the TSH in the gland, promoting more hormone synthesis and more hormone release, ending up with Graves' disease and hyperthyroidism. So the cells are hyper and secreting more thyroid hormone because it is a stimulatory process. But the two pathology of the disease are autoimmune. Whether it is Hashimoto thyroiditis will end up with hypothyroidism, or Graves' disease will end up with hyperthyroidism. These two conditions of autoimmune, you can face them in pregnancy, pre-pregnancy, or after pregnancy. Here we can see the thyroid antibodies causing Hashimoto thyroiditis, thyroid peroxidase antibodies, or thyroglobulin antibodies, as we said this earlier. Here, let us talk about the lab changes during pregnancy. As you know, in normal adult, the TSH level, non-pregnant cases, the TSH is between 0.3 to 4.2. Is it the same for pregnancy? No, it's not. Then what are the normal physiological level of TSH during pregnancy? Let us see. Here we are talking about the TSH normal ranges in pregnancy specific to trimester. So trimester specific TSH references are in the first trimester 0.1 because it is first trimester, 0.1 to 2.5. Second trimester it's 0.2 to 3. Third trimester it is 0.3 to 3. So it's easy to remember. Trimester specific TSH reference ranges. So if you want to find out whether this patient has abnormal TSH, you compare it to these ranges of pregnancy and don't compare it to the normal adult range, because you will miss cases as hypo because your reference was the normal adult. Don't make the reference normal adult, but make your references the trimester specific reference ranges. In this slide, I want to show you the similarities between different glycoproteins. These glycoproteins, all of them, they share a common alpha subunit. TSH share a common alpha subunit with the FSH, with LH, and with the human chorionic gonadotrophin. So when the human chorionic gonadotrophin share similar unit with TSH, then it will go and occupy its receptor in thyroid gland. Then this will send a false message to the anterior pituitary not to secrete TSH. That's why TSH you will find that less in pregnancy, but this is normal. And don't label these patients as hyperthyroidism because of the similarity between the TSH and the human chorionic gonadotrophin makes its level less, doesn't mean there is some major pathology. No, it's not hyperthyroidism. This case will explain more and more what we discussed in the previous slide regarding the similarity between TSH and the human chorionic gonadotrophin, the hormone of pregnancy. A 31 years old lady, she's 8 weeks pregnant now, means she is in the first trimester. Her TFT showed thyroid function test, T3 normal, T4 normal, but the TSH is 0.2. 0.2 is low, but does not mean this is a case of subclinical hyperthyroidism. No, because we know that the normal reference range of TSH during the first trimester is 0.1 to 2.5. So this is normal. If any female patient, known case of hypothyroidism, and she is euthyroid, stable on a fixed dose, for example, of thyroxine, as soon as she gets pregnant, you need to increase her thyroxine dose before the result of thyroid function test reaches you. How much to increase is by 25 to 30%. Now let us take a case that will make us understand deeper the concept. 31 years old lady, 8 weeks pregnant, diagnosed case of hypothyroidism since 3 years, and she was euthyroid since that time, taking thyroxine. You did a thyroid function test for her, and she is, remember, 8 weeks. T3 normal, T4 normal, and TSH is 0.2. And as we remember, this is normal TSH level in the first trimester. So you came to know that she is pregnant now, and she is taking specific thyroxine dose. What you will do, what's your next action plan, is to increase her thyroxine dose by 25 to 30%. Got it? What is the incidence of hypothyroidism? Hypothyroidism complicates up to 3% of pregnancies. 3% of our pregnant ladies are hypothyroid, and it might be higher in this part of the world. The hypothyroidism is two types: subclinical hypothyroidism and frank hypothyroidism. Subclinical hypothyroidism, where the T3, T4 normal, the TSH is high. Frank hypothyroidism, where the T3, T4 low and TSH is high. How much is the prevalence of hypothyroidism? Frank is 0.3 to 0.5. But if it is subclinical hypo, it's commoner actually, 2 to 2.5%. Do we need to treat patient with hypothyroidism in pregnancy? Yes. Do we need to treat subclinical hypothyroidism in pregnancy? Again, yes. Now, you came to know that hypothyroidism can occur in pregnancy, whether it is frank hypothyroidism or overt hypothyroidism we call it, or the other type of hypothyroidism, which is the subclinical hypothyroidism. If the patient is diagnosed hypothyroidism and not on treatment, what do you think might happen to her? She might go into preeclampsia, gestational diabetes, cesarean section, increase the rate of cesarean section in cases of hypo missed not on treatment. They can end up with preterm birth, placental abruption, maternal anemia, and postpartum hemorrhage. So it is significant complications in pregnancy can happen to the mother if we don't diagnose and treat her hypothyroidism. What about the baby? What are the worst fetal outcome can happen to the baby? Fetus of women diagnosed hypothyroidism, they are at risk of small or large for gestational age. They can have fetal distress at any time, or they can have or develop neonatal respiratory distress syndrome after delivery, and they might need an ICU, or they can have malformation from the beginning. So it's really important to diagnose and treat cases of hypothyroidism in pregnancy. How to treat cases of hypothyroidism during pregnancy? Suppose you diagnose a case of hypothyroidism during pregnancy. What will you treat her with? You will say L-thyroxine. Definitely you are right. But how much is the dose? The dose between 1 to 1.5 microgram per kg once a day. And how to follow the effect of your medication on the mother? By repeating her thyroid function test 4 weeks after you started the treatment and find out whether you need to increase or decrease the dose you gave her. Adjust the dose each time, targeting the trimester-specific TSH range. Remember? What are your targets while you are treating case of hypothyroidism in pregnancy? Your targets are to keep the T4 in the upper range of normal and to keep the TSH below 2.5 in the first trimester and below 3 in the second and third. Subclinical hypothyroidism. Do you remember when we defined what subclinical hypothyroidism means? It means that in the thyroid function test, you find the T3, T4 normal, but the TSH above 3. You diagnose this case as subclinical hypothyroidism. Do you need to treat this case? Yes, you need to treat it, but not with the same dose of frank hypothyroidism. You might need to treat it with smaller dose, like you start with 50 microgram OD for the pregnant lady and follow her thyroid function test. Subclinical hypothyroidism is caused by the high titer and the high level of antithyroid peroxidase antibodies or antithyroglobulin that initiate and start the inflammation in the gland. This will attract lymphocytic infiltration to the gland, causing lymphoid follicle, destroying the thyroid follicles, ending up with subclinical hypothyroidism. More infiltration, more apoptosis, more necrosis. This will turn the gland into or end up with frank overt hypothyroidism. Now, hyperthyroidism in pregnancy. What is the prevalence? It occurs in 0.1 to 1% of all pregnancies. It is less than the incidence of frank or subclinical hypothyroidism, but it can occur, and smart doctors like you should not miss it. How you diagnose a case of hyperthyroidism during pregnancy? You diagnose that when the TSH is low, and it is quite low in pregnancy sometimes, 0.1 or 0.3 or 0.2, but in the same time, the level of T3 and T4 should be high to diagnose this case as frank hyperthyroidism, which needs treatment. Graves' disease. You know from the basic science that Graves' disease, it's an autoimmune condition. It's caused by the thyroid releasing antibodies that binds the TSH receptors at the thyroid cell, promoting and enhancing the cell to form more and more of thyroid hormone and to release it into the circulation. So it's basically an autoimmune process. And Graves' disease is the commonest cause of hyperthyroidism in the reproductive age group ladies. Graves' disease is the most common cause of hyperthyroidism among fertile aged women. Look at this lady eyes. On the right hand side, her photo before having the disease, or you can say after the treatment. You can see her eyes are normal looking with no lid lag or lid retraction. But you can see on the left hand side the starey look of the eyes, where there is lid retraction. Or if you examine her, you might find lid-like. So I sign in case of hyper, suggesting always Graves' disease. Hyperthyroidism in pregnancy can cause maternal complications. It can cause miscarriages, or patient will be prone to develop preeclampsia. Or if the thyroid hormone is high with sympathetic overstimulation, it might end up with maternal cardiac dysfunction or even heart failure. The effect of the hyperthyroidism on the baby also is a quite significant. Complications can happen, like low birth weight or fetal growth restriction can end up with cardiomyopathy, fetal cardiomyopathy, or retinopathy of prematurity. Eyes get affected, or neonatal thyroid disease. Why? Because the maternal thyroid stimulating or releasing antibodies will cross the placenta, goes to the baby, and when it goes to the baby or fetal thyroid gland, it will stimulate the gland to release more and more thyroxine. So the baby will be less weight, low birth weight, and heart will be racing, might end up with cardiomyopathy or heart failure. We call this condition as neonatal thyrotoxicosis. Management options of Graves' disease in pregnancy. Outside pregnancy, when you want to treat hyperthyroidism or Graves' disease, there is 3 options you suggested on the patient. But in pregnancy, we cannot do that actually. It's limited. Options are limited to us for pregnant lady. The 3 options are the antithyroid medications, which is a good option to suggest it for the patient, thyroidectomy, let's talk about this, and radioactive iodine. Please don't suggest that for the pregnant lady. Radioactive iodine is not an option to use it to treat hyperthyroidism or Graves' disease during pregnancy because it is very harmful and cytotoxic to the fetus. Thyroidectomy, is it an option? Yes, it is an option, but it is not the first option, and we don't suggest it for a pregnant lady unless we have pressure symptoms, because achieving euthyroid can be done by the drugs, but if it is big gland compressing on the trachea causing respiratory disturbance, then we have to take it out, preferably in the second trimester, but whenever it causes symptoms, it has to be taken because now respiration are in danger. So thyroidectomy can be done during pregnancy, but it's given or it's not selected unless patient is having pressure symptoms from the gland. Now, when we want to treat hyperthyroidism or Graves' disease in pregnancy, the first option to choose is the antithyroid medications. There are 2 medications can be used, the propylthyracil and the carbimazole. To start with, for propylthyracil, you can start with 50 twice or thrice daily. You can reach up to 150 TDS. The carbimazole is you start with 5 mg twice daily and you can reach up to 15 mg. These are the antithyroid medication can be used during pregnancy. But are they trimester specific? Do you prefer one over the other during the first trimester? And why? Carbimazole is one of the antithyroid medication can be used during pregnancy, but it's not preferred to be used for the first time during the first trimester. Why is that? Because of the susceptibility of congenital malformation caused by carbimazole. What are those congenital anomalies can happen? Aplasia cutis, where is patch of the skin has no scalp has no skin and no hair, and cleft lip or tracheoesophageal fistula. These are known side effects of the use of carbimazole in the first trimester, so try to avoid using it if you are using this antithyroid medication for the first time in the first trimester. Propylthyrosol is an antithyroid medication that's preferred to be used in the first trimester because, as we discussed, the side effect of carbimazole. But it's not preferred to use it in the second and third trimester. Why is that? Because of the high susceptibility of developing drug-induced hepatitis because of propylthyrosol. So it is for the first trimester and not for the second and third trimester. So now, if you want to summarize the use of antithyroid medication during pregnancy, for the first trimester, you should use propylthyrosol. And for the second and third trimester, to use carbimazole. To minimize the congenital anomaly in the first trimester, use propylthyrosol. And to minimize the drug-induced hepatitis effect in the second and third trimester, use carbimazole. When you decided to put the patient on antithyroid medication, how you will follow the case, how you will follow your patient to make sure that she is reaching the level of euthyroid. When you started the first dose, like the initial dose of 50 milligram of propylthyrosol twice daily, you do thyroid function test or you request thyroid function test for your patient after 2 to 4 weeks and find out what is the effect of the medication on the test. If you are approaching the euthyroid state, then keep the same dose. If you need to increase the dose, then build up the dose. So the minimum effective dose is the role here in treating case of hyperthyroidism. And the same applies for carbimazole. You start with a small dose and build up your dose if you need, and your target is to use the minimum effective dose to reach a euthyroid state for your pregnant patient. As you know, that Graves' disease is an autoimmune condition. And you know in the same time that pregnancy is a state of less immunity. So the antibody titer during pregnancy might decrease as pregnancy advances. And as long as the antibodies are suppressed or decreased, then the disease process will decrease. So patient might not have the effect of these antibodies and so not having the hyperthyroidism. What about the treatment the patient is on? You might be giving her propylthyrosol of 100 twice, or she might be on carbimazole 15. Then, as the pregnancy advances and these antibodies fades, then patient might not need these medications, and she might go even into hypothyroidism, which mandates you to stop the medications because you don't want your patient to be in an euthyroid, and giving her antithyroid medication will induce hypothyroidism and ending up developing hypothyroidism while you were treating a case as hyperthyroidism. Both has side effect on the maternal and fetus, and you don't want that. You want an euthyroid state during pregnancy. Do you remember when we talked about fetal thyrotoxicosis or fetal hyperthyroidism? You know that this is induced by or caused by the maternal thyroid releasing antibody, which passes the placenta to reach the baby thyroid gland, enhancing more thyroid synthesis and release into the circulation of the baby. It will end up of loss of weight, small for gestational age, preterm labor, and even racing heart, end up with cardiomyopathy or heart failure to the baby. This is called fetal hypothyroidism. When the baby is delivered, will be taken by the neonatologist and treat them accordingly. Suppose patient is euthyroid during the last trimester on no medications, and she is a case of hyperthyroidism or Graves' disease, but you needed to stop the medications as her antibody titers decrease lower and lower and lower, which mandates you to stop the medications. What do you expect after delivery to happen? What can happen? Yes, relapse, flare up of the disease after delivery because of the immune status of the lady will recover again. So you expect this patient to have hyperthyroidism, needs treatment after delivery. So you will put them on antithyroid medications which are safe during lactation. After we discussed hyper and hypothyroidism during pregnancy, we should not forget to talk about postpartum thyroiditis. What is postpartum thyroiditis? It is a new onset of thyroid dysfunction, which occurs in the first 12 months after delivery. So, patient was euthyroid during pregnancy and pre-pregnancy on no medications, but she has high titer of antithyroid peroxidase antibodies or thyroglobulin antibodies. This makes her 50% higher chance to get postpartum thyroiditis. Out of the patient of whom they develop postpartum thyroiditis, 50% they are prone to develop frank overt hypothyroidism or permanent hypothyroidism later in life after the postpartum thyroiditis presentation. What are the diverse of postpartum thyroiditis presentations? Postpartum thyroiditis can present to you as hyperthyroidism or hypothyroidism. You can see this patient when she complains of symptoms of hyper, or you can see her in the postpartum period, the first 12 months, when she's complaining to you as hypo. If she complains of hyper, then she is in the initial stage. If she complains of hypo, she is in the later stage. Because there is phases of postpartum thyroiditis. The first phase is hyperthyroidism. The second stage is hypothyroidism. And the third is euthyroid. But 50% of these women can end up with frank hypo forever. So if the patient presents to you in the first 12 months after delivery complaining to you of insomnia, restlessness, loss of weight, easy cry, irritable, restless, all this might tell us that this patient is suffering from postpartum thyroiditis and not hyperthyroidism. And when you do the thyroid function test and find thyroid function hyperthyroidism, it could be a temporary stage of postpartum thyroiditis and not frank hyperthyroidism lasting forever or chronic hyperthyroidism. So you have to follow this patient. If she turns to have later hypothyroidism, then this confirms to you that this is not a hyperthyroidism post-delivery but postpartum thyroiditis. If you are facing these cases and diagnosing them as postpartum thyroiditis because during pregnancy and pre-pregnancy they were euthyroid but antibodies titer are high, then you have to treat them with only beta blockers and not antithyroid medication. Why is that? Because it is because of inflammation there is excess release of stored thyroxine, but not excess synthesis of thyroxine from the gland. So you will not give them antithyroid medications, but to suppress the sympathetic overdrive, you'll be giving them only beta blocker. If you see them in the hypo state, then you will be giving them thyroxine, the proper dose of frank hypothyroidism, 1 to 1.5 microgram per kg. But you have to follow them up. So, not every hyper comes to you after delivery is chronic hyperthyroidism. Especially if her thyroid function test was normal during pregnancy and pre-pregnancy. You might label this patient as postpartum thyroiditis, and you need to follow her up, and the treatment is only beta blocker. If you see the patient in hypostate, she might be temporary because it is postpartum thyroiditis, and 50% of them recovers completely. So you have to follow this patient even if they are giving them thyroxine. Management of postpartum thyroiditis. To summarize the treatment and the management of postpartum thyroiditis, when you see a case of hyperthyroidism postpartum and you diagnose her as postpartum thyroiditis in the hyperthyroid state because she was euthyroid during pregnancy and pre-pregnancy, only antibody titers are high, then you treat her only with propranolol and not antithyroid medications. But if you see the patient in the hypothyroid phase and you diagnose her as postpartum thyroiditis in the hypothyroid state, especially when she is euthyroid during pregnancy and pre-pregnancy, only antibody titers are high, then you treat her with thyroxine therapeutic dose 1 to 1.5 microgram per kg. When the patient reaches the state of euthyroidism, you do TSH annually. Why is that? Because those patients are prone to develop frank hypothyroidism in 50% of cases. But when? We don't know. So annually, we have to follow their TSH level. These are the references if you want to go and read more. By this, we came to the end of our video of thyroid disorders in pregnancy, how to diagnose them, and how to treat, and how to keep patients safe during pregnancy and the postpartum period. Thank you very much, brilliant, smart doctors. See you inshallah next video discussing another medical disorders in pregnancy.